Hi, everyone. My name is Brittany Miner. I am the coordinator for the Missouri Aging and Disability Research Network. And today we are going to have a presentation on coronavirus and aging. The presentation will be done by Dr. Nancy Morrow-Howe and Natalie Galusha, and I'm going to let them introduce themselves. So, Dr. Morrow-Howe, take it away.
Thanks, Brittany. Natalie and I are coming to you from the Center from our homes, but from the Center for Aging, the Harvey A. Friedman Center for Aging at Washington University. I am on the faculty at the Brown School and the director of the Center for Aging. And Natalie, you want to introduce yourself?
Sure. So I work with Nancy at the Center for Aging as well. I'm the manager of our center and have been there for just about a year, and I'm also a graduate of the Brown School of Social Work.
So Natalie and I have worked with our colleagues, you can see them on the screen there, to put together a bit of a presentation, sort of the intersection, how we view this epidemic, this pandemic, and age and ageism. So we want to share some ideas with you. I acknowledge my other authors. I also want to say I heard a really nice reframe yesterday, and it was not that we keep saying that, are you working from home? And it really is, we're at home in a crisis trying to work. So we appreciate that when we hear the dogs and the babies and the internet's going out. So I like that reframe. Okay, so here's what we're going to talk about today. An outline for our presentation. As you see, it's very socially oriented. I'm a social worker and a social gerontologist, not an MD or infectious disease person. So this is our take on these issues as we think about our current situation in older adults. Also, a caveat about data, it's changing so rapidly. We tried to update our numbers a bit for this presentation, so there's some old numbers and some new numbers, but data is changing rapidly, and it's going to take us a while to figure out what we are experiencing and how this virus is really playing out. And we are using information from blogs and discussion boards, really wanting to reflect perspectives and ideas, so I hope you'll have some reactions to this as well. So the question is about age and this virus. And there is a lot of evidence that suggests that there's a real strong relationship between age and dying from the virus. As age goes up, severity of illness goes up and mortality goes up. Here's slides on data in the US. As you can see, age is related to mortality and to hospitalizations. You have to remember our population is about 15% are older adults, but a third of the cases of the virus are confirmed in people 65 and older, and 80% of the deaths. An interesting thing to note is that about half of the ICU admissions are folks under the age of 65, but only 20% of the under 65 age group has died. So this shows that that if a person is more likely to recover if they're under 65, even if they needed to be in the ICU. Here's a little more recent data just from a couple of days ago. The trend is continuing as age goes up, mortality from the virus goes up. Although people are focusing in on that pretty high number in the young old, trying to understand age distribution a little more finely than just folks, older folks. So that's what data is looking like in our country. In China, where it's been going on the longest, now only 9% of China's population is over the age of 60. 65. 9% are over the age of 65. But you can see that 31% of the confirmed cases are over 60 and 81% of the deaths. So China's not a very old country compared to our population, but very much indicated that the virus is taking its toll on older bodies. The data from Italy is even more profound. The average age of the person who died in Italy was 80. Clear linear relationship there. So people have been speculating why is and the death rate, this is a little bit old data, this was from the end of March, but the death rate in Italy was quite high from the virus, higher death rates than we're seeing here. And people are speculating that it's because the population in general, it's one of our oldest countries, like 23% of the population is over the age of 65 in Italy. So a lot more older people proportionally to begin with. There's more intergenerational living and intergenerational mingling in that society. There's high rates of smoking, and the healthcare system truly got overwhelmed. So people are going to be looking back at these times by country, trying to figure out why death rates varied that were more sort of social determinants of this phenomenon. In fact, people here, as you know, are starting to look at how vaping might be affecting some of our figures, and also how space, the use of space between cultures and cities, and crowds coming together in different spaces is culturally and socially determined, affecting these rates. So some interesting learnings will be had about that. So the question on the table is, so okay, older adults are more likely to die, but why? What is it about age? How is age linked to the virus? And the bottom line is that older adults are at increased risk. It's not age per se, it's the fact that older people are more likely to have chronic conditions, more likely to have weakened immune systems. So that first set of factors are biological, that older bodies are more likely to be in vulnerable because of those two conditions that are associated with but not determined by age. We call it multiple morbidity, and compromised immune systems comes with both primary and secondary aging processes. Another social explanation of what age has to do with it is residential living. Older adults are more likely to be in congregate housing, to be in retirement communities, to be on a cruise ship. And it's close proximity that is the issue, not age per se. And in fact, we have shut down our dorms at WashU, as you know, to prevent contagion. And it's a big issue about how we're going to bring people back into those kind of living situations. Nursing homes, we know, are set up. They have been, this is nothing new. Nursing homes have always been vulnerable to viruses and to contagions as an issue because of because the most vulnerable people living in nursing homes in close quarters with staff going between the rooms and hygiene just being a challenge in that kind of a situation. So it's particularly hitting the nursing home industry, as you all know. So those are some of the reasons what age has to do with it. It's because it's related mainly to pre-existing conditions. So here's some data that shows that positive correlation between chronic conditions and deaths from the virus. So you can see there that 3/4 of that pie of deaths in Italy had 2 or more chronic conditions. I couldn't get real up-to-date national data. Natalie found this, I believe, or one of our people working on this found this, that underlying conditions in Alabama. These are the underlying conditions that are most associated with the disease. Cardiovascular, which is, of course, one of the most common chronic conditions in later life, diabetes, renal, etc. It was interesting, they looked at the folks who didn't, in Alabama, they looked at the folks who didn't have any underlying chronic conditions. It was a small percent. 17 deaths were confirmed among those with no underlying conditions. And most of those folks were still older. They were older, 82% of the folks who died without any underlying conditions were 65 and older. So another interesting data from the CDC is where people are dying. I just wanted to get updated information up here to show that most people are dying in hospitals, but then nursing home or long-term care facilities very disproportionately represented. You know, at any one time in this country, 3 to 4% of people over the age of 65 are in a nursing home. So those percent deaths are way out of whack with the number of people who are proportionally to the population. So the bottom line, it's not age per se. Its age is associated with weaker immune system, more chronic conditions, and living in different residential settings. So chronological age, one of the biggest take-homes for us as gerontologists is that chronological age is a bad proxy. It is a proxy, but it's a bad one. I'd like to, as gerontologists, we all know, stepping back a little bit, that people say, well, how old is old when you talk about the older population? It's really going to depend on the country, depend on the subpopulation, really. So then there's going to be no demarcation. So make sure you're clear when you talk to people about this. In China, in lots of parts of Asia, 55 and up is considered older. Globally, this World Health Organization will use 60, and we use 65. So there's no demarcation that's based on biology or psychology or sociology. It's only based on policy, right? On legal and policy precedents that sets any kind of age for what is older. And chronological age is not an indicator in itself, and I like the quotes I put up there to indicate that. The second major point about older adults, if we're talking about older adults in the virus, is there's so much heterogeneity. We know that as gerontologists. Older adults are more different from each other than any other age group. A totally mixed bag of physical, mental, economic, cognitive conditions. No two 70-year-olds are alike, and one is as fit and functional as they've ever been in their lives, and another could be in very, very bad shape. So we cannot let age be used as a proxy for so many of these things. We do talk about a wide range of health and functioning in the older population, and we're going to show you some fun statistics. I'm not a person who likes to talk about the exceptions, because most of us aren't the exceptions that have lived through the Spanish flu and then lived again through COVID-19, but some very interesting human interest stories about folks who did live through the Spanish flu and are reflecting on the COVID pandemic right now. In fact, the oldest person in the US, a woman in South, I can't remember if she's in Georgia or Alabama, Hester Ford, was 13. She's alive today. She has dementia. She's alive today, but she lived through the Spanish flu. And I like this newspaper way back when that, so nothing new, we need to wash our hands. And here's these stories that pop up of somebody that made it through this virus, and they also made it through the Spanish flu. So just an interesting story about age. I just love the life course kind of perspective when we think about these issues, and love that these older folks are spotlighted for all that they've been through. So what I want to focus on a little bit today is ageism in this whole scene. And this pandemic is exacerbating many isms, and we are all aware at WashU and in our student community, and our scholars really more generally, the xenophobia and how much discrimination and acts of unkindness have been expressed towards our students from Asia, our faculty and students that are even Asian descent. So there are so many isms that are being exacerbated. We're going to talk about racism and classism a little bit later in this presentation, but focused right now on ageism. Ageism is certainly easy to stir up in this country because it's alive and well and just barely under the surface. So any kind of crisis is going to exacerbate it. But many things about the pandemic have been attributed to reduced concern about and value attributed to old people. It's been said that countries were slow to move because only old people were at risk. The treatment and mitigation protocols have been more adequately developed for children and youth in certain hospitals. saving the economy is more important than saving older lives. We've even heard the old phrase, thinning the herd, and the newer phrase, boomer remover. So ageism is alive and well, and in fact, a wonderful author, Louise Aronson, Dr. Louise Aronson, had an article in The Atlantic pointing out how ageism is making the pandemic worse, that it's dangerous, but she even called out internalized ageism, which we all know is ageist ideas that older people hold about themselves, that we grow up learning about negative attitudes and thoughts about aging, and it takes a toll on us. And she pointed out that some older people are failing to identify as old or at risk because it means acknowledging their age. She pointed out that many of us tried to not be perceived as old and not make necessary steps to protect ourselves. So going with her idea that ageism is dangerous, we'd like you to think about the fact that attributing vulnerability to age puts younger people at risk. If younger people think that they are impervious, they are not going to do what they need to do to take care of themselves. And in fact, when it was first so attributed to later life, young people didn't feel like they were going to need to be protected from it. In fact, now it's more clear that people of all ages are dying, although there's this linear relationship to age. Younger people are getting the virus in unexpected ways, really struggling with it. So if people are attributing it just to age, younger people aren't going to do what they need to do to protect themselves. But more than that, if it's attributed to later life, younger people may be less motivated to do the right thing, right? To be part of the common good in regards to social distancing. I'm looking at my notes here that says if people, for example, in Florida beaches think that this is not about them, that it's only about old people, they're going to be less motivated and less likely to play their vital role in mitigation. And it's becoming clearer that younger people do play the most vital role in mitigation. Modeling suggests that the impact of distancing among low-risk people is more important than distancing among high-risk people to decrease the transmission. So in other words, older people are counting on younger people to be part of the common good to protect older people. So there's this interesting relationship, but basically it says that ageism and age stereotype hurts younger people, and it hurts older people as well when younger people don't think they're vulnerable. Ageism also raised its head in some of the early discussions about rationing care. We know that in Italy, ventilators needed to be rationed. And that's when we first started hearing about people needing to revisit guidelines and study guidelines. And there was some language, those who are too old, they have a high likelihood of recovering or have too low a number of life years left. Those kind of things were seen in guidelines. In this country, ventilators, it looks like, have not been as much of an issue for rationing yet, or maybe not at all if we're lucky, but dialysis machines have been. So protocols about rationing have been under review by people. And it's interesting that, oops, I thought I had a slide here. Makes me worried that I don't have my recent, there was recently a statement came out from the U.S. Office of Civil Rights. I can't remember who it was. I've lost the slide. Just reminding people that we need to be rationing on survivability, and age is not something that should be brought into that calculation. So when you ask older adults, when this idea of rationing first came out, if you remember, the governor of Texas said that, of course, senior citizens will be willing to sacrifice for younger folks who are sick and hypothetically need ventilators. This is the voices of people that say there's no one answer, right? Older adults are the most heterogeneous group, and you're not going to have one voice about this issue. So in the first example, this was a person that said, heck no, I'm 69, I'm in good health. I don't want people to think that I shouldn't get that ventilator. I'm extrapolating there, but I'm getting the heck no at the top and the heck yes at the bottom, where some older adults will be willing to do what it takes in the face of rationing. In the middle, saying maybe if I knew that it would help my children. So you're not going to get one voice out of older people in terms of anything that has to do with sacrificing their lives. So bottom line is, there's what I was trying to get to. Age neutral, triaging for care should be age neutral. And these are some comments from my colleagues at GSA, warning that if we thought about rationing based on survivability, the can of worms that we open up about health disparities in these countries are unimaginable, thinking about poor people, ethnic minorities, homeless people, who are, of course, have lower possibility of surviving. And people referring to the fact that Dr. Fauci, our leader through all of this, is going to be 80, I think in December. I think at the end of the year he turns 80. And certainly we don't use age as a criteria in thinking about him. Here it was, his U.S. Civil Rights Office rejects rationing based on disability and age. Just feeling the need for a statement to come out in the face of some of the language about age and rationing. Okie dokie. I'm going to talk a little bit about ways that older adults are being affected by the virus. We know that social distancing is key. We know that older adults are greatly affected by this, as well as all populations. But we know that social isolation is associated with those. We've known this a long time. Social isolation has been at the forefront of our thinking for probably a decade now. It's been a very popular topic because we've documented how bad it is for us, physically, emotionally, cognitively. And we know that it affects everyone. But we also know in this epidemic that older adults were pressed to isolate, and more strongly are still being pressed to isolate more strongly because of their increased vulnerability. Although age is a bad proxy, it's sort of a clear proxy. So older adults, no contact with grandkids, stay home, people can't go see you if you're in a residential setting, etc. It's hard on everyone, but older adults go into the situation at higher risk of social isolation. Remember, we can't generalize, but as a whole, in surveys, if you were going to document social connectedness, older adults are generally less socially connected. Why? They've lost their partners and friends, many do not have work connections due to retirement. Some have transportation limitations. We're more likely to live alone. So going into this pandemic, older adults were at increased risk of isolation. And that's why it's been on everybody's radar in the more recently, and now it's being exacerbated by this. So we are very concerned about the disproportionate burden of isolation on the older population. We have to talk about cumulative disadvantage, disproportionate burden. It's a concept we all use in aging, right? A cumulative disadvantage, how social, economic, environmental, and health inequities follow people into older adulthood. Unequal burden of chronic disease, in older populations, but especially low income and communities of color. So the addition of this burden in those different categories. And then of course, these marginalized groups having less access to insurance, comfort with providers, ability to pay, and more. So cumulative disadvantage and aging in this virus certainly is being played out in our community. These are some current stats that we're all seeing now as data is coming out on race. Age is not overlapped here. And it's interesting, I was just seeing a seminar that's coming up at the Brown School on racial disparity in the face of COVID-19. Such an important topic. But the interesting thing is it's not being overlapped with age. And we know that it's cumulative disadvantage. We still know that there's that linear relationship with age. So Black Americans that are older are at the highest risk. So I don't want that message to be missed. I really think cumulative disadvantage where age, race, class, etc. Intersect to create the greatest vulnerability. So you can look at those stats from across the country. Explanations have to do with higher rates of exposure, in terms of employment, people that are still working and on the front lines working in stores, etc., are more likely to be people of color. Underlying health issues because of lifetimes of discrimination in our healthcare system and lifestyle privileges, and lower rates of insurance and difficulty accessing medical care. So I would like us as gerontologists to sort of overlay age with some of these ethnic stats that are coming out. And again, coming back to our focus on ageism just for this presentation, thinking about how we can resist ageism. An author pointed out, what other demographic would be so crudely represented without some sort of a blowback? In other words, we can say crudely, she's talking about crudely representing older adults, right, as represented in this way in this pandemic. Would we do that with any other demographic? I take that to mean, you know, would we do this by class or by education or by cognitive capacity? You know, hopefully not, at least not publicly, but we're much more publicly willing to go there when we think about older adults. Some other just nice quotes from people in the literature or in the press telling us that age tells us nothing about people, and the moral decay that it would represent if we devalued any person, any group, is such a slippery slope to moral decay. So what can we do about it? Thinking about this ageism, we need to become aware of it. The first thing is be aware that we are willing to do that and that we need to call people out when they talk about age as a proxy. We need to also resist ourselves using age as a primary definer of people. But we can also think about the language that we use. We can talk about the common good. So much of what we do is connected to individual action. Individually, we need to wash our hands and social distance, but we are washing our hands and keeping our distance to protect everyone in our community. We need to talk about risk beyond age. There's lots of people at increased risk, children out of school who don't have food, restaurant workers without a paycheck, healthcare workers on the front line, people that are isolated, people that have underlying health conditions, people with immune systems that are weaker. So in other words, we're trying to get age out of our language and talk about real vulnerabilities. My big question for us going forward is a lot about how can we foster intergenerational solidarity and come out the other end of this without more intergenerational divide. It's been a setup for that intergenerational solidarity. I think that what we can do is to highlight, celebrate, spotlight, promote in our work, in our communications, the good works of younger and older people as we try to take care of each other. We found this meme early on about us, kind of a younger person laying on a couch, talking about your grandparents were called to war. You've been asked to sit on a couch. You can do this. At first I found that clever and cute. And then I'm more concerned that it's a bit of a shaming or an intergenerational comparison or conflict. So I just think we have to be really careful in how we message things, but that we should be messaging about intergenerational solidarity right now. Natalie and I and some colleagues are getting an article published, hopefully it'll be online this week, that's looking ahead past post-pandemic, acute pandemic at least, and older adults particularly, to sort of get ahead of things that we're going to need to recover from and take advantage of things that we think are more positive. So I want to just take a few minutes to tell you some of our ideas there before we open it up for questions. We aging advocates are concerned that there's going to be a setback in our efforts to confront the image of old age as a state of frailty, vulnerability, primarily in need of help and compassion, that we are set back in those regards, and that we need to mount our efforts to confront ageism more strongly when we get through this. Of course, the impact of the economic shutdown on everybody is tough, but what we know about aging is that unemployment rates are going to be just higher than they think than the Depression. And older adults generally fare pretty well at layoff time, but they do very bad at re-entry time, so that older workers are going to be less likely to become reemployed after this. And sometimes older workers are leaving jobs because of their sort of at-risk status, that maybe they're not doing as well as younger workers because they feel like they really can't go into the store to work because of their age. And then they're going to have a harder time getting back in. We know that from experience. Part of the reason we know that is that when there's a lot of people applying and there's a lot of competition for jobs, older people do worse, probably because of implicit age bias on the part of the employer. When there's a lot of people, they can fall back on stereotypes and snap judgments about older workers. The effects of this income loss, but on stock market decline, is going to be real for a lot of people. We know that there was a trend toward working longer going on anyway, of people re-entering the workforce after retiring, of on-court careers. There's probably going to be more of that. People are going to need to stay working longer or return to work. So our efforts to better support older workers are going to have to continue strong. And that does mean fighting discrimination in the workplace, because older workers report discrimination and then they have more depression and more health decline and less job satisfaction. Another thing about workers who have needed to leave the workforce and looking to come back, more people are just going to retire. You know, they're going to say, well, the older adults will look for a while and then they'll involuntarily claim retirement because of their inability to get back in. We don't know about the long-term effects of social isolation. We know that anxiety is on the uptick. We know that people are dealing with helping people manage anxiety. We don't know the effects long-term of the social isolation that we know is related to physical health and cognitive health. One of the concerns is just the erosion of our services in this time of crisis. We know that our work with AAA, I'm not sure if any of our service providers are on the line, I'm sure that they know this, the erosion of our community services. We don't know the long-term effect of that. We know that congregate meals aren't happening, and people are scrambling to serve people that need meals. We know that in the home care industry, we know that home care workers and clients alike are canceling services due to the exposure and the risks. So we know that there's a lack of attention to personal care, diet, med management. You know, what's the longer term effect of this is going to yet to be seen. That's really related to the next one down there, the ramifications to routine health care. So we were talking about our community and social services, but the healthcare services, and you all have stories of yourself and your family who have not been able to get routine care. And we don't know the long-term effect of that. Physicians have worried about the disruption to diets and high blood pressure and unmonitored things and delayed surgeries. And the concern that as soon as we open up, there'll be such a backlog, this routine care situation is going to drag into the future for a while. So our thinking about how to help ease that recovery. Also, we don't know about the physical impact of the virus on bodies who have sustained the virus and lived. We're concerned about damage to the heart, damage to the lungs, etc. And then finally, we do know that we have spotlighted the health and economic disparities in older adults of color and lower socioeconomic status, thinking about how to keep that spotlight on rather than letting it go away as it does, so that maybe we can try to move with more determination to decrease disparity. There's lots of positive things we can think about, and this is the funner part. But we know that we have been jump-started in terms of our technology skills. There was a trend towards older adults becoming more tech-savvy, using smartphones, etc. And now there's sort of this sink or swim moment for many people where we will teach online, right? That's what I had to learn. So it's a sink or swim moment, and there's no going back. We're trying to get computers and computer training to folks, to older adults who haven't had those resources through some of our community agencies. So hopefully it's a great leap forward in terms of technology skills for all of us. We know that there's lots of stories of family and intergenerational connection that we can continue to strengthen through virtual interactions. There has been a spotlight on social isolation in ARP, and in different countries have had national campaigns against social isolation. This pandemic has just spotlighted that, so hopefully we will have increased momentum to confront that problem. An interesting uptick in advanced care planning. Before the pandemic, we had a statistic that 27% of Americans had documented their end-of-life wishes. In March, there was a 10-fold increase in the number of requests for advanced care planning documents through 5 wishes. So people are paying attention to the importance of talking to relatives and friends and getting paperwork in order. I think that's really been exacerbated when people have died so alone without anybody able to be there in their last days to talk to about any of this stuff. So we can keep that momentum going. The growth, the have to move to telemedicine and mobile health and working from home, those things have all just jettisoned us into the future, and we can learn some things. I really like this one about greater appreciation and respect for self-care, management, and meaningful engagement. There's so many sources now, online, newspapers, talk shows. Everyone is calling attention to the importance of self-care, to schedule, to sleep, to diet, to exercise, to social connection. And they're sort of really becoming important now. We usually think, oh, that's something I'll do later. But every day, we're called to think about self-care. And we're also learning firsthand how we use our time. Some of us have the luxury of being able to work from home. Some of us aren't able to work from home, so we're home. And we need to figure out what gives us meaning. We're disconnected from jobs, professional connection, volunteer roles, grandparent roles, routine social gatherings. So it's sort of this time to, as Joe Coughlin has said, he runs the MIT lab at the MIT Age Lab. He says this is a fire drill for retirement. This is a trial run for how we spend our time. I think that's a very interesting way to look at this time for us to be looking for ways to help people figure out how to self-care and time manage for the most healthful kind of living we can do. And the last thing I'll say is Natalie and I think it's, maybe Natalie, you can come in at the end here and tell us about careers in aging is happening. I don't know if it's next month or whatever, but careers in aging has always been a thing. Can we use this time to get people more interested in careers in aging? We know that we have spotlighted nurses and doctors and psychologists and social workers and public health people and health administrators about the pandemic. How can we interest them in public health and issues of aging society and take advantage of this moment? And that would include interests in reducing disparities and increasing social justice, that we have seen the need for as well. Natalie, do you want to mention Careers in Aging Week? Or what is it, month? What is it?
Sure. Yeah, it's a week. So right now it is currently Careers in Aging Week. It started on Sunday and will go through Saturday, technically. It is sponsored mostly by the Gerontological Society on Aging, but there's a bunch of other larger aging organizations that are involved as well. But if you go to GSA's website, they have a bunch of information about it. We are hopefully today going to be releasing some stuff on the Institute for Public Health and the Center for Aging's website about it, and a little an article about the staff at the Center for Aging, and then some different things highlighting careers in aging and encouraging other people to be involved in really highlighting all of the different types of careers that you can be involved in the aging field.
Yeah, thanks. Let's turn to, we do know there's so much information out. Our agencies have done such a good job getting information out to people who have the luxury of being able to get it. We just put up one, we did this presentation for a larger community group and wanted people to know some numbers. I'm sure our partners have all kinds of resources for us if people have specific needs. So with that, we got some time. Natalie and Brittany, do we want to have any discussion or take any questions?
I think it'd be great to take questions if anyone has any. And you can post it in the chat or you can chime in. I thought it was interesting that you said that there is an uptick in people working on their wills and end-of-life planning, and it reminded me that a lawyer I know had posted that they were, I think, making efforts to get people access to that faster and at a discounted rate currently. Here in Missouri, I'm not sure all the details, but it is something that I think a lot of people don't think about, and when there's a pandemic going on that's affecting all ages, that's definitely something people probably should be thinking about.
Yeah, and Natalie, did you see it? Or maybe Susie, maybe somebody saw it. I think in Missouri, they scrapped the need to have something notarized that would require, somebody going somewhere and being with somebody. I think states have relaxed some rules about getting those documents official.
Yeah, it was in I think it was in the last government little thing that they did when they talked about the stay-at-home orders. They were updated that.
Wow, nice.
Good to know.
So thank you so much, Nancy and Natalie. This was really food for thought. And I love so just contextually, I really appreciate your comment of the overlay of race and aging. And I want to also overlay disability on top of that. Because, that Venn diagram center is kind of really the heart and the soul of the folks that this group that you're looking to focus on. And I completely agree. These are the most vulnerable citizens that we have, and they're really taking the brunt of so many isms. And so I'm really wondering, I love what can we do going forward? So what are the things that we can do for community agencies, for us as academics, for all of us to think through what are the responsive things that we can do? I love the telemedicine idea. We're working hard on our lab at figuring that out. But what innovations have you seen, or what do you think we'll need to do to be responsive?
Yeah. Do you want to, Natalie, anybody online that want to give us some, I just have ideas, but I'm sure you all do too. I think the question is, how can we minimize the negative and maximize the positive things that could come out of that? Because there's a lot if we start articulating and thinking that. So what are some of the best ideas?
This is Margaret Campbell. I'd like to throw something in.
Oh, hi, Margaret.
Hi there. Hi, everybody. I think it's related. I'm sure we all read yesterday that ACL is getting almost $1 billion in this new legislation that hopefully will be signed by tomorrow at the latest. And is that a vehicle? Will that provide, I mean, I read briefly, you know, it's going to go to the ADRCs and a whole bunch of other aging-related entities. But would that provide a vehicle to do some of the things you're talking about, Nancy, in terms of looking to the future and how we can change delivery of services and et cetera? So I'll stop there.
Yeah, I haven't read the details of what people are thinking about that money, but that would be wonderful. Thank you, Margaret. It also makes me think about the spotlight that's been thrown on the people on the front lines, and especially people in hospitals, obviously. But you know, I'm thinking about the home care, nursing home care, the home care workforce, and how important. I just hope that we come out the other end with the importance of our workforces that are so underpaid, under-trained, under-advanced, all of the things that we know that makes that workforce so marginalized. If we can't come out with greater respect for that workforce and some improvements in their jobs and their lives, and that would seem like it'd be a very important thing for the for that federal money and look to be on. Because, you know, older workers are parts. Yeah, go on, please.
I think it's something like 50% of that almost $1 billion is going towards home and community-based services.
Right.
And I think, you know, I think there's some opportunities there for people to apply for grants to do some innovative things. So I think it's important to kind of mobilize the Aging Services Network to think, how can we, you know, apply for some of this money to do to improve services, improve the work conditions for the workforce, and deliver more effective services that address, you know, self-care, self-management of chronic health conditions, and a whole number of things. But this is a windfall. I mean, I hate to say it in those terms, but it is a windfall. It's a huge infusion of money. And, you know, I'm not central to the Aging Services Network, but I hope the organizations that support, professional organizations, people that support that network, are really thinking how to use this money as an opportunity to do some of the future-looking things that you've been talking about.
Right. Yes. That's something that we need to keep our eyes on. What other ideas do we have?
I see Amy mentioned that she's looking for best practice ideas for social isolation. Are there any new innovative best practices that folks are aware of that have emerged?
I'd love to hear, because everything I hear, there's a lot of attention on it, but there's not a ton of innovation.
Yeah, we've been interested in connecting, not necessarily for isolation, but for tele-rehab, and we're not getting great opportunities to connect with technology for this population, mostly because they don't have the resources to maintain computer networks, and so they are kind of promised the technology for this more vulnerable, less economically privileged group is not as optimistic as we'd hoped.
Yeah.
We're working on the COVID response team, sort of addressing what they're calling a homebound older adults and people with disabilities. And, you know, we know that this isolation piece is big, but it's just hard to wrap your arms kind of around how do you address that thing. We can deliver a meal, we can deliver groceries, we can do some of those really practical things. But I think, you know, what some people really need is people.
Yeah.
It plays into the technology issue a little bit, Susan, that you were just talking about, but I have seen something, there are some newer organizations popping up. There were some students at WashU that started one called Students to Seniors that recruits either college or high school students, gives them some training, and then matches them with an older adult. I think it's more like a Zoom type meeting, but I don't know if they do phone conversations as well, but it just allows them to at least, you know, have an interaction and conversation with someone. And the same thing with, there are virtual senior center type programs as well, which again, some of those are more virtual through Zoom, but it, you know, it could be something like even a chair yoga class or trivia or bingo or something like that. And some of them do have just a phone option as well. So if you at least have access to a phone or
Yeah.
again, that, you know, just gives you a little bit more interaction. So there's a bunch of different things that are popping up like that too.
So Natalie, do you have, like, for example, the WashU students, like, do they have capacity to take on, like?
They, as far as I know, yes, because I actually heard from them. They had sent Nancy and I an email a couple of weeks ago that they actually have more students than older adults at the time. I don't know if that's changed because it's been a couple of weeks, but I think right now they do have the capacity to take on more.
They were still recruiting last week, and Amy, I can share a flyer with you. That
Great. Terrific.
That would be great, because I think that'd be good to use for our group as another resource.
Sure, no problem.
Yeah, I know that OASIS is currently working on, they have a call out for applications for people who are trying to start some new innovative social isolation reducing practices.
Right.
And I think those applications are due like May 1st or the beginning of May, but I don't know how many responses they've gotten so far, or what kind of applications they're giving.
Sarah Page still on the call? I saw she was.
Yes, I saw Sarah was on the call. She would know.
I don't think she's still here.
Okay.
I think she might have had to hop off, maybe.
I'm going to add one thought to this. You know, from being thrown online teaching, we've all learned this new concept of synchronous and asynchronous. You know, things that we're going to do before that people look at and things we got to do in real time. You know, that concept seems to be so critical in sort of what's the balance between what people can do online and what's the balance between touch and telecommunication and online and offline. So I've just realized that that's a question. You know, what's the right balance to achieve the best outcome? We're trying to figure that out in teaching, but surely that applies. And the other thing is we're developing all these apps for contact tracing, right? We're going to know who we walked by that had the virus. And I know there's all kinds of issues with that, and does it work in you know, privacy and all that. But I would think that the leap in technology on human connection is going to be pretty huge. So I'm hoping some people are thinking about that just in regards to social connection.
Hi, Nancy. Sorry to jump in and interrupt. My name is Marissa, and I'm a project coordinator with OASIS. So Sarah was not able to be on the call after 12:30, but I wanted to kind of follow up. I know you were talking.
Oh, great.
Grant.
Marissa.
Yeah, hello. So I apologize. Of course, I'm not near as knowledgeable about the grant that Sarah is, but yeah, so it's called Community Care Corps is what the grant's for. And you're right, May 1st, I believe, is the date the RFPs are due. And it's looking for, the main focus is social isolation as well as helping advocate and for new and innovative strategies for non-medical caregiving. So that they're looking for kind of just the sky's the limit. They're not giving out too many examples. They really want innovative. They don't want people to get stuck in the box from, if some examples are given. So they're really excited. I know there's been quite a few applications submitted. And
well, thank you.
of course, yes. Sorry, I'm not Sarah, but I thought I'd address it as I could.
Were there any other questions that came in? And we, this was recorded, but we also have these PowerPoints that people can take advantage of if they want to pull out anyone to use or to think about. So let us know. I participate in a national group through the Gerontological Society of America called Reframing Aging. And they are really going at this now big time to talk about how we can reframe things for a more positive outcome, over time. Yesterday I was on a seminar and they talked about how the way we think about it now, how we talk about it now, has so much to do with how things will unfold in the future. I don't know what the answers are, but that made me realize that we should try to be taking advantage of this very, very different moment. And they're the ones, yesterday on the seminar is where I heard the reframe that, we are not working from home. We're at home in a crisis trying to work. I mean, that's really different for families. That just that minor reframing of how we think about something has a lot to do with how we treat each other, and how we think about improving things. So let's hope we can all keep together and get some good progress from this really hard time.
I agree. Thank you, Nancy. This has been, I think it's an opportunity for us to come together, people that work on issues of race, issues of disability, issues of aging. We are all in this pot, this vulnerable pot together.
Yeah.
When the more we can maximize our resources and do things together to address all those issues, return to work, be at home, addressing isms, I think the better off we'll be. So hopefully that will spark some ideas.
Yeah, and thanks, Margaret, for giving us a heads up. We'll look more carefully to see how that money's going to be, opportunities that might arise.
The thought just occurs to me, one thought, the school districts have done, across the country, have done such a great job of at least loaning computers to students. I mean, there's been a massive effort during this shutdown period.
Right.
That doesn't eliminate all the technology barriers because obviously there still has to be internet, etc. But I wondered why, again, states and agencies couldn't apply for some of this money and include money for loaning computers and providing technical assistance and internet services. I mean, I think when we start talking about services, we have to really think of technology services as part of the package that enables their services instead of just a luxury or instead of, and I think that this might be, I mean, I love to design grants and love to help people write grants, of course, but I think that could be tucked in, not just tucked in, it could be made very salient in applying for some of this money, is how you're going to use some of the money to provide technology supports to senior centers, to other entities, but also to individuals, loaning out computers and providing, whether it's through student help or through other kinds of help, actually having a workforce that are tech consultants that can help people know how to interact with bingo meetings online or Zoom meetings, things like that, because I think some of the barrier is motivational. Some of it is obviously, it might not have enough internet connectivity, but some of it is just the overcoming the inertia of how do you get on and how do you do these things and how do you participate. And so anyway, just thinking about, instead of just always talking about technology as the barrier, how can we make technology part of the service delivery?
Yeah. Yep. That's what we've had to do in a crisis. And I think there's no going back. There need to be a going back.
And the school districts, I live in a rural area now here in Western Washington, and the school districts, you know, we have lots of poor kids, and the school districts are doing a terrific job getting computers to all these kids and helping the families. And I just don't know why Aging Services Network can't do that too.
Yeah.
I think that's a great thought. And I think it addresses a lot of the issues we brought up.
Yeah, I think our village, our St. Louis village here is, we've thought about that and tried to problem solve at the individual level with people and had some success, but not the resources to really to do it. So yeah, thanks for those comments.
Awesome. Well, I guess we can wrap this up. We will make this available to our network, our community-based research network for sure, so that people can access this. And I know Nancy and Natalie will be available for those of you who log in later. If you need connections, let Brittany or I know, and we will get you connected, Nancy and Natalie. And
Great. Thank you for this opportunity.
Thank you so much for presenting.
Thank you both.